About 60% of our bodies is just water. It's this incredibly critical balance, but it's so delicate that even a tiny shift can cause some major problems. So today, we're going to dive deep into what happens when that balance gets thrown off by a condition called the syndrome of inappropriate antidiuresis, or SIAD for short.
All right, so here's our game plan. We'll start with how the body normally handles water, then look at how that all goes wrong in SIAD. After that, we'll get into diagnosis, treatment, and a really important topic, the dangers of fixing the problem too quickly. And then we'll wrap it all up with the key takeaways.
To really get a handle on what's happening in SIAD, we first need to meet the main character in this story, a tiny but super powerful hormone that's basically running the whole show.
And that hero is antidiuretic hormone, or ADH. The best way to think about it is like a gatekeeper for water at your kidneys. Its whole job is to open these little water channels called aquaporins to let water flow back into the body when you need it, and then close them up to let excess water out when you're good. It's all about keeping things in that perfect Goldilocks zone.
So normally, this system is just beautiful. It works like a perfectly tuned feedback loop. Let's say you get a little dehydrated. The concentration of stuff like salt in your blood, we call that osmolality, it goes up. Special sensors in your brain pick up on this and signal the pituitary gland to release ADH. ADH then scoots down to the kidneys and tells them, hey, hold on to water. That water then dilutes the blood back to normal. And once the balance is restored, boom, the ADH signal shuts right off. It's super elegant and efficient.
So, the big question is, what happens when this perfectly controlled system just breaks? Well, that's exactly where we find the syndrome of inappropriate antidiuresis. And really, the name tells you everything. The antidiuresis, the holding on to water, is happening when it absolutely shouldn't be. With SAD, that gatekeeper, ADH, is basically stuck with the gates wide open. ADH is just pouring out, completely ignoring whether the body is hydrated or not. The kidneys, they're just following orders, so they keep reabsorbing more and more free water. This leads to way too much water in the body, which dilutes everything, and most importantly, it dilutes your sodium. That condition is what we call dilutional hyponatremia, and it is the absolute central problem in SAD. So what makes this ADH go rogue? Well, the list of causes is incredibly long, which is a big reason SIADH is so common, especially in people who are in the hospital. It can be caused by some cancers, like small cell lung cancer, which can actually start making its own ADH. It can be triggered by problems in the brain, lung diseases like pneumonia, and a whole bunch of really common medications. Heck, even things like intense pain or nausea can be enough to set it off. Okay, with that many potential causes, figuring out if a patient actually has SIAD takes some serious clinical detective work. It's what we call a diagnosis of exclusion, which means we have to carefully rule everything else out first. Let's think this through for a second. If the body is holding on to way too much water, what's going to happen to the blood? It's going to get watered down, right? Diluted. And what about the urine? If the kidneys are constantly being told to pull water out of the urine they produce is going to be super concentrated. This right here, this paradox, is the key to the whole diagnosis. And this slide really lays out that paradox in black and white. To nail the diagnosis, we need to see that low sodium, hyponatremia, and a low plasma osmolarity, which confirms the blood is dilute. But at the exact same time, the urine osmolarity is way too high. The urine is concentrated. Now here's a really, really important piece of the puzzle. The patient has to be euvolemic. That's a fancy word that just means their total body fluid is normal. They're not dehydrated, but they're also not all swollen and puffy. And of course, we have to make sure other things, like thyroid or adrenal problems, aren't the real culprit. One of the classic conditions that can look a lot like SIAD, especially in patients with a brain injury, is something called cerebral salt wasting, or CSW. They both can give you low sodium, but the absolute key difference, and you have to get this right, is volume status. In SIAD, patients are euvolemic. In CSW, they're actually losing both salt and water, so they're dehydrated or hypovolemic. This distinction is critical because, as you can see, the treatments are polar opposites. How a patient presents also really depends on how fast their sodium level drops. If it tanks in less than 48 hours, what we call acute hyponatremia, the brain has zero time to adapt. Water floods into the brain cells, causing them to swell. This is cerebral edema, and it can lead to seizures or even brain herniation. It is a true medical emergency. But if the sodium drops slowly, over days, that's chronic, the brain is smart. It adapts by getting rid of some of its own solutes to match the dilute blood. In these cases, the symptoms can be way more subtle, like a little confusion or just being unsteady on your feet.
All right, let's talk about fixing this. How do we restore the balance? The single most important rule of treatment is this. You treat the patient and their symptoms, not just the number on the lab report. And you have to do it carefully.
The approach really depends on how sick the patient is. If someone is having severe neurologic symptoms like seizures, we don't wait. We immediately give them a special IV fluid called 3% hypertonic saline. The goal is to raise their sodium just enough, maybe 4 to 6 points, to pull that excess water out of their swollen brain cells. It can literally be life-saving. For more moderate symptoms, we focus on fixing the underlying cause and usually start with fluid restriction. And for those chronic cases where the person feels fine, the main treatment is just restricting their total fluid intake, usually to a liter a day or less.
Now, if just restricting fluids doesn't do the trick, we've got other tools in the toolbox. We can use diuretics with salt tablets to help the kidneys get rid of free water. We can give a substance called urea, which basically pulls water out into the urine. And then we have a class of drugs called Vaptans. These actually go in and block the receptor that ADH uses, but they are very powerful. Tolvaptan, for example, has a black box warning because if you're not careful, it can raise the sodium way too fast. And that brings us to what is, without a doubt, the most critical part of managing SIAD. In our rush to fix the low sodium, it is frighteningly easy to cause an even worse problem. Correcting sodium too quickly can be far more dangerous than the low sodium itself. I really want this to sink in. When you are treating chronic hyponatremia, your mantra has to be slow and steady. This is not a race. The stakes are as high as you get, and the damage can be permanent. So here's what happens. Remember how the brain adapts to chronic low sodium by getting rid of its own solutes? Well, if we come along and raise the sodium in the blood too fast, the whole balance reverses violently. Water gets ripped out of those adapted brain cells, causing them to shrink. This process damages the protective coating, which is called the myelin sheath. This stripping of the brain's insulation is called demyelination, and it leads to a devastating condition called osmotic demyelination syndrome, or ODS. It's a catastrophic and often irreversible brain injury. To prevent this from ever happening, we have a very strict speed limit. For patients at high risk, the absolute goal is to raise their sodium by no more than 6 to 8 milliequivalents per liter over a full 24-hour period. This isn't a suggestion. It's a hard and fast rule you have to respect. If you ever find that you've broken that speed limit, you have to slam on the brakes immediately. First step, stop everything you're doing that's raising the sodium. Then you may actually have to give electrolyte-free water, like a D5W infusion, to carefully bring the sodium back down a bit. In some situations, we even give a drug called desmopressin, which is basically synthetic ADH, to put a temporary stop on the kidneys losing water. That gives us complete control to slowly and safely re-lower the sodium back into the safe zone. Okay, we have covered a ton of ground here. Let's take a minute and just boil it all down to the absolute most important takeaways from our deep dive into SIAD. These 4 points really are the whole story. First, always remember, SIAD is a problem of too much water, not too little salt. Second, the diagnosis hinges on that paradox: dilute blood, concentrated urine, and only after you've rolled out the mimics. Third, treatment is all about the patient's symptoms, from emergency IV fluids to simple fluid restriction. And finally, and maybe most importantly, osmotic demyelination syndrome is a terrible complication, but it is preventable. Always, always respect the speed limit. And that leaves us with one final thought to chew on. As more and more people are on multiple medications, especially older adults, preventing SIAD caused by those drugs becomes incredibly important. So what's the most effective thing we can do to anticipate this and keep our vulnerable patients safe? That's a huge question for the future of medicine. Thanks so much for joining this explainer.